second session of the free papers. I would like to invite our chairperson, Dr. Vinod. We welcome you, sir. He is the professor and head of the Department of Psychiatry at Manakulaba Nayagar Medical College. Instructions, 5 minutes for the presentation and 2 minutes for questions and doubt. There'll be a beep sound, and at 5 minutes, the stopper will be guiding both of you. So we would like to start with the first presenter, Dr. Atulya.
Good morning, all. My study is on premenstrual dysphoric disorder, its prevalence, effect on quality of life, and disability associated to it among medical and nursing students. Premenstrual dysphoric disorder is a severe and disabling form of premenstrual syndromes with prevalence ranging from 3 to 9%. This disorder consists of a cluster of affective, behavioral, and somatic symptoms. As this illness occurs on an average of 7 days per month throughout the woman's reproductive years, the burden of illness due to PMDD is very high. Premenstrual symptoms cause impairment in physical, psychological health, severe dysfunction in social and occupational areas, poor self-esteem, a sense of dissatisfaction, inadequacy, and an unhealthy lifestyle. Justification. Still, the need of further researches on this topic is recommended, as not much literature in our country has focused on this topic. Also, the population that we have studied are more prone for risk factors like loneliness, work stress, lack of family support, which might add to the risk of PMDD. So in this context, the study is conducted among the medical and nursing students. Aims and objective of my study: to estimate the prevalence of premenstrual dysphoric disorder among medical and nursing students, and to study the effect of PMDD on the quality of life and disability among the medical and nursing students. Methodology: it was a cross-sectional study conducted at Dhanlakshmi Srinivasa Medical College, Perambalur. Target population was nursing and medical female students. Convenient sampling. Study period April to June 2022. Sample size of my study was 445. Data collection tools. Structured questionnaire was used to collect basic demographic data, age at menarche, duration, and regularity of menses. Standard scales used were premenstrual symptom screening tool to assess the severity of PMDD. WHO quality of life brief scale, it was used to assess the quality of life, and Sheehan disability scale to assess the disability domains. So these were the premenstrual symptom screening tool with symptoms such as anger, irritability, anxiety or tension, fearful or increased sensitivity to rejection, depressed mood, decreased interest in work activities, decreased interest in home activities, decreased interest in social activities, and how these are affecting in their work efficiency or productivity, their relationship with co-workers, social life activities, and home responsibilities. Data analysis. The data that's collected is entered in Microsoft Excel sheet and analyzed using SPSS 21. ANOVA and chi-square test is used to find the association. Results. Among the 445 participants, 428 students submitted the completely filled questionnaire. So the results were given for 428 students. Prevalence of PMDD in this study is 4.45%. This is the distribution of PMDD. In number of participants, 80.1% participants didn't have no symptoms, 15.4 had moderate symptoms, and 4.5 had PMDD. So these are the distribution of functional impairment in school efficiency, relation with classmates, relation with family, school life, and home responsibilities. Quality of life is affected in PMDD. This is a disability affected in work, social or leisure activities, family responsibilities, with p-value less than 0.05. Coming to discussion part, the prevalence of PMDD is 4.55%. The duration of menses of more than 6 days has significantly higher odds of having PMDD in our study. The anger, fatigue, physical symptoms, and decreased interest were most common symptoms in PMDD. Similar to our study, Swami et al. Found the most common symptom reported was fatigue or lack of energy, 68%, followed by decreased interest in work and anger and irritability. The mean scores of physical and psychological, environmental, and social domains in quality of life is significantly lower in PMDD when compared to no or moderate PMDD in a study. The mean scores of work, social activities, and family responsibilities in disability is significantly higher in PMDD when compared to no or moderate PMDD. Similar to a study, the study conducted by Taka et al. Have shown prevalence of 5.3% and the lower mean scores of quality of life in students with PMDD. The study by Nizar et al. At Pakistan, it showed consistent and strong relationship between PMS symptoms and level of interference in all domains of women's quality of life, similar to our results. The same study by Taka et al. Have shown similar results with disability, where there was significantly marked disability scores among women with PMDD. Come to the conclusion part. We conclude that PMDD has significant effect on quality of life and daily activities. We recommend an early screening and diagnosis program of PMDD among reproductive age group, which will lead to early management and improve the quality and productivity in their life. Limitation of my study, only medical and paramedical students were enrolled in a study, so results can vary on generalizing to all reproductive population. Data were obtained through a self-reported questionnaire, so false reporting could not be avoided. These are my references. Thank you.
The floor is open for questions. Anybody? If there's no questions, it's a good study. But my question is like it was 400 plus, right?
Yes, sir.
How did you have a discussion with them? Was it a Google form or you had a one-on-one session with them?
Sir, like we have gone to the class and we have explained about the study to this thing. And most of the people there from the medical background, so like the understanding was good. It was through Google Forms. Thank you, sir.
Thank you, Doctor. It's a pleasure to welcome our another chairperson, Dr. Iqbal Sharif. He's the consultant psychiatrist and founder of Nisha Hospital at Tanjore. We welcome you, sir. Moving on to the next presenter, it's Dr. Rachna. You can start your presentation.
Good morning to everybody. My study is on digital screen time and its association with sleep quality among medical students, which is a cross-sectional study. In a recent time, a rise in number of websites and social media groups has encouraged young people to spend more time on digital gadgets. And nowadays it is very common because also it is of online education and entertainment platforms is more. An upsurge in digital gadget use was seen during the COVID-19 pandemic as the people were forced to stay at home. And the blue light and the electromagnetic fields emitted by these devices causes disruption in the circadian rhythm. Blue light leads to melatonin suppression, which is the facilitator of the sleep. Justification for the studies, several study has done in the past has found an association between increased multimedia exposure and health issues. While most people are aware of the danger of cell phone radiation, but they are less aware of the extra negative impacts of increasing screen time on physical health, visual, musculoskeletal system disruption, and sleep quality. Also, the medical students have more access to digital devices and spend more time on internet, social media in order to get away from stress and loneliness. In this context, the study is conducted among medical students. Objectives to estimate the prevalence of increased screen time among medical students, to determine the association of increased screen time with quality of sleep. It is a cross-sectional study done in Dhanlakshmi Srinivasan Medical College, Perambalur, among medical students, which is a convenient sampling. And data collections tool was done by structured questionnaire using basic demographic data like age, gender, residence, BMI, screen time in hours per day, and bedtime gadget use. And scales used here is PSQI, Pittsburgh Sleep Quality Index. As per WHO guidelines, BMI less than 25 is categorized into not obese category, and BMI equal to or more than 25 into obese category. And screen time we have divided into less than 2 hours is normal and more than 2 hours is increased screen timing. And bedtime gadget use is we have taken here as using gadgets after going to bed and before sleeping. And sleep quality is done by Pittsburgh Sleep Quality Index, where more than 5 indicated poor quality, and sleep quantity, total hours of sleep per day in average, sleep latency, time taken to go for sleep after going to bed. If it is more than 20 minutes, then we are considering here it to be a increased sleep latency. And data analysis is done by using SPSS 21, and the independent t-test and chi-square test is used to find an association. P-value less than 0.0005 is significant. Results among 340 participants, only 322 participants gave a form completely filled questionnaire. So the results were taken for only 322 students. And it's a table where it is showing among 322 students, almost 238 people were using gadgets at bedtime, that is 73.9%. And prevalence of screen time among 332, 69.2% is prevalent for increased screen timing. And mean screen time per day is 6 hours plus or minus 1 hour. And poor sleep quality was prevalent in 60.9%. Increased sleep latency was prevalent in 46.8%. Mean sleep hours is 5 hours plus or minus 1 hour. And students with obesity have a significantly higher proportion of increased screen time. And here the students have increased screen time per day, has higher proportion of poor sleep quality and increased sleep latency. The mean number of hours of sleep is significant higher in students with screen time less than 2 hours when we are comparing to students with screen time more than 2 hours. And bedtime usage of gadgets and sleep quality, an increased proportion of poor sleep quality among students who used gadgets at bedtime when compared to non-usage of gadgets at bedtime. The results were very significant. And the discussion part is there is significant association between sleep quality, quantity, and latency with increased screen time in our study. Similar studies like Yogesh et al. 2014 has showed a increased screen hours have significant association with less sleep duration, sleep disturbance, and increased sleep latency. And the sleep quality is poorly associated with increased screen time. And another study by Eluri et al. 2021 has shown the screen time has positive correlation with poor quality of sleep, irrespective of gender among MBBS students. In my study, obesity is positively associated with increased screen time. This may be due to decreased physical activity, increasing energy intake from eating while viewing, and reducing sleep. And the another study by Robinson et al. 2017 stated that the screen media exposure leads to obesity in children, adolescents through increased eating while viewing. Here my conclusion is increased screen time have a significant association with sleep quantity, quality, and latency, and bedtime gadget usage seems to have a significant relationship with sleep quality. We recommend a need for health education implementation for all medical students on the impact of screen time usage in health and sleep hygiene. Limitations to my study is it is a self-reporting scales were used, and which always carries a bias, and other variables like physical activity, loneliness, conflicts with family members and friends were not included in the study, which is one of the limitations in the study. And these were my references. Thank you.
Floor is open. Anybody want to change? It's a good study. When did you do the study?
April to June last month.
Yes. Less than 2 hours is normal.
According to who?
Anybody came for the treatment?
No. Right.
Thank you, Dr. Rashna. Our next presenter is Dr. Kavaskar from Trichy.
Good morning to all. My study is to estimate the prevalence of depression among elderly inmates of old age homes. Depression is one of the most common illness in the elderly population. According to WHO, depression is a common mental disorder characterized by sadness, loss of interest or pleasure, feelings of guilt or low self-worth, disturbed sleep or appetite, feelings of tiredness and poor concentration. India is the second most populated country in the world in terms of elderly population of 60 years and above. Elderly depression is not yet perceived as a public health problem in India. Among elderly people, chronic diseases, restricted mobility, bereavement, elderly abuse, isolation, loss of income are major risk factors of depression. The aims and the objectives of study is to estimate the prevalence of depression among elderly inmates of old age home, to find out the prevalence of depression among older adults living in old age home and factors associated with care and management of these individuals. The study is conducted April and May 2022 in 2 old age homes in Trichy district, approved from Institution Ethical Committee, formal permission from the concerned authority of the old age homes, and also informed Written consent from the participants by briefing the purpose of the study was obtained. A pro forma for socio-demographic data and geriatric depression scales were administered. The study is cross-sectional study conducted to old age home 3 district and inmates of old age home conducted in April and May 2022. Sample size is 60. Materials used semi-structured pro forma for socio-demographic data and geriatric depression scale 15 questionnaire. Data analysis, descriptive and statistical analysis done using SPSS software 26. The GDS scale is 15 item measure, scored 1 or 0 for yes or no. Personal integrity 3, emotional stability 4, social stability 2, mental hygiene ideology 3, and vitality 3. The interpretation of GDS 15 is 0 to 4 score is no depression, 5 to 8 is mild, 9 to 11 is moderate, and 12 to 15 is severe. The inclusion criteria of the study is subjects are individuals living in old age home, age 60 years and above, persons willing to participate in study. Exclusion are person who had previous psychiatric illness, chronic medical illness, dementia patients were excluded, person who are not giving informed consent to participate in a study. Results in my study is, in our study 60 participants were included. Among these, males were 53.3% and females were 46.7%. The mean age of the study participant was 68.8 plus or minus 6.8 years. In this study, prevalence of depression was found to be 65%, among which males constituted 56% and the females is 44%. Among these, mild depression was 40%, moderate is 20%, and severe depression was 5%. The study shows positive correlation between the age and severity of depression. As the age increases, the severity of depression is also increased. The percentage of physical comorbidity subject is systemic hypertension is 32%, diabetes 25%, diabetic and hypertension 6.7%, and seizure 3.6%, cardiac problem 1.8%, respiratory problem 1.8%. The discussion in our study, the prevalence of depression was found to be 65%. In another study conducted in Udupi in Karnataka, the prevalence of depression was found to be 48%. The findings of the present study is consistent with a study carried out among geriatric population in Nepal, which showed majority were experiencing depressive illness. Among them, 34.2 were mild, 19 were moderate, and severe is 4%. A similar finding is noted in a cross-sectional study on prevalence of depression among Malaysian elderly, which found that the level of depression is significantly associated with variables like gender. However, the prevalence of depression disorder in older adults was found to be 21.7% Bara and Gar, 22 by Nandi and in Bengal, 13.5 by Tiwari. These differences in the prevalence of depression compared with the present study might be due to different instruments used for measuring depression and also their larger sample size. The limitation of this study, the sample size was small and restricted to only 2 old age homes. Moreover, no formal diagnosis of depression was made in the sample used in the study. For determining gender difference, both male and female constitute of the sample should be equivalent in all respects. In future, longitudinal studies on the larger group of elderly men and women living in old age home are needed. This is my references. Thank you.
Study, but I have a doubt here. Like before you started the study, did you look into the past history whether they were already suffering from depression or anything?
Yes, sir. No past history.
No past history.
Thank you.
Thank you, Dr. Gavaskar. Can we have the next presenter, Dr. Chandra Jyoti?
Very good morning to one and all gathered here. My study topic is cross-sectional study on self-esteem and its association with psychotic features in symptoms with schizophrenia, in patients with schizophrenia. I thank my faculties for helping me to do this study. Coming to the introduction, self-esteem is defined as individual assessment of self-worth and self-knowledge about themselves, Low self-esteem makes the individual vulnerable to psychiatric illness, and psychiatric illness lessens one's self-esteem. It's a vicious cycle. Low self-esteem being a risk factor or an association factor in mood disorders, schizoaffective disorders, delusional disorders, and substance use disorders. Low self-esteem is accounted for persistence of delusions and associated with even the contents of the patient's delusion. Studies have reported significant correlations between negative self-evaluation and wide variety of positive symptoms in patients with schizophrenia. They have significant low self-esteem in comparison with other psychiatric disorders. There are very few studies done for correlation between the negative symptoms of schizophrenia and the self-esteem. I would like to do this study to find the association between negative symptoms of schizophrenia and self-esteem and the prevalence of low self-esteem among schizophrenia population. Coming to the aims and objectives of the study, to determine the level of self-esteem in patients with schizophrenia, to determine the association between low self-esteem and the psychotic symptoms and associated with the socio-demographic profile. Methods: patients diagnosed as schizophrenia as per ICD-10 criteria attending outpatient department for treatment in our hospital were recruited as study population. After obtaining approval from institutional ethical committee, after obtaining informed written consent from the patients, pro forma for socio-demographic data, positive and negative symptom scale questionnaire, and Rosenberg self-esteem questionnaire were administered. Coming to the Rosenberg self-esteem scale, it is developed by Dr. Maurice Rosenberg in the year of 1965. It's widely used as a self-report questionnaire for evaluating individual self-esteem. It's a 10-item scale, measures global self-worth by measuring both positive and negative feelings about self. All items were answered using a 4-point Likert scale ranging from 1 to 4. Items 2, 5, 6, and 8, 9 were reversely scored. Interpretation of the score was low self-esteem. The points score is less than 15. Normal score between 15 to 25. High self-esteem score is more than 25. Coming to the positive and negative syndrome scale, it is developed by Stanley Key and Louis Opel and Abraham Festi in 1987. This scale is used to assess the symptom severity. It's a gold standard test to assess the symptom severity in patients with psychotic symptoms. It's a 30-item questionnaire, contains 7 questions for positive symptoms and 7 questions for negative symptoms and 16 questions for general psychopathology symptoms. It was scored as 7-point Likert scale. Higher scores in each domain indicate higher severity. Composite score is measured by subtracting the negative score from positive score, ranging minus 42 plus to plus 42. Different score reflecting the degree of predominance of one syndrome in a particular individual. Inclusion criteria: patients diagnosed to have schizophrenia as per ICD-10 criteria who attends a psychiatric OPD for treatment and follow-up. Age between 18 to 60 were included. Persons willing to participate in the study are included. Exclusion criteria: patients with schizophrenia with comorbid significant mood symptoms, substance use disorders were excluded, and persons with chronic medical illness or neurological disease and dementic people were included. Study design: it's a cross-sectional study done at the Department of Psychiatry, psychiatric OPD. Schizophrenia patients attending in a psychiatric OPD patient. Study conducted period of April 2022 to June 2022 with the sample size of 60. Coming to the data analysis, descriptive and statistical analysis using SPS software 22. Total population were 60 participants. Majority belongs to the age group of 18 to 30 years. Were males, 70% were educated up to graduation, and they were belonged to low socioeconomic status, and most of them were unmarried, had a positive family history, and low self-esteem was found in 71.7% of study population. Coming to the descriptives, low self-esteem was found in 71 to 7%. Mean score for low self-esteem was 8.16 with a standard deviation of 2.38. Mean score for positive symptoms is 23 with a standard deviation 11.5. Mean score for negative symptoms was 34.2 with a standard deviation 10.8. Mean score for general psychopathology is 86. Results based on group statistics on independent t-test and ANOVA. There is significant mean differences observed in gender, working ability, and positive family history, and with the low self-esteem population. No difference was found in variables like age, socioeconomic status, and mean negative symptom score and general psychopathology score was differ significantly among low, high, normal self-esteem population. Correlation studies, negative symptoms and general psychopathology score were has significant negative correlation with self-esteem. Coming to the discussion, we have found that low self-esteem is present in 71% of population with schizophrenia. We found that low self-esteem is present in patients with predominant negative symptoms and who have high general psychopathology symptoms. We found a significant negative correlation between the level of self-esteem and general psychopathology. Limitations of the study: sample size is very small to estimate the prevalence with adequate precision. Predominant positive symptoms and lack of insight in patients who predict high self-esteem score. Longitudinal studies and case control studies were done in future to know the causal association between the self-esteem and negative symptoms. These were my references. Thank you. Patient is on treatment who are come for follow-up. Sometimes, yes, sir. No, sir, we have not. Thank you.
Thank you, Doctor. Our next presenter is Dr. Daniel Sundar.
Good morning, sir. My topic is on burden and quality of life in caregivers of patients with severe mental illnesses and common mental disorders attending in a tertiary care institute at Chengalpattu district. Introduction. Caregivers play a critical role in supporting the sick family members as they provide both personal and emotional support to their relatives with a mental disorder. Patients' well-being is directly linked to the quality and nature of the care they receive from the caregiver. Caregivers' quality of life, including work, socializing, personal relationship, may suffer as these results of these demands. 1/3 to 1/2 of these caregivers suffers significant psychological distress as they have higher rates of mental distress according to a study on the impact of caregiving. Hence, the patient receiving care may suffer as a result of strain placed on the caregiver with severe and common mental illnesses. Both the knowledge on this extent of the strain where the caregivers, the quality of life are limited. Hence, this study was undertaken. Objective is to study the subjective component of burden and quality of life in caregivers of patients with severe mental illnesses and common mental disorder. Methodology is a descriptive cross-sectional study. Study setting in OPD in Karpaganagar Medical College in Psychiatry Department. Study duration 6 months. Study population. The primary caregivers or with the patient who is coming for the Psychiatry Department OPD. And the operational definitions, the primary caregivers are a patient with mental illness is a person who lived with a patient for at least 6 months and involved in providing care and support to a patient with mental illness. Severe mental illnesses like schizophrenia, bipolar or non-organic psychosis, common mental disorders like depression, generalized anxiety disorder, panic disorders. Inclusion criteria, those who fulfill the primary definition for the definition for a primary caregiver in a patient, and the age group of 18 to 65, exclusion, age less than 18, and caregiver who have a previous known case of psychiatric illness were excluded. And a study instrument, socio-demographic performance was applied, and PHQ-9 in view of relevant information in getting about depressive disorder, and burden assessment scale was used. In this factor, 5 factors were there, and quality of life BREF scale was applied. The flow of study, primary caregivers were coming with the patient, and those who were informed consent was obtained, and 3 scales were applied along with the socio-demographic performer, and the caregivers were evaluated, and ethical permission was taken from their college, and as a result, and the study, there are totally samples of 187. 111 caregivers are from severe mental illness and 76 caregivers from common mental disorders. Among 50% are from age group of severe mental illnesses are 41 to 50 years. Among common mental disorder, 46% are from 30 to 40 years. There are female proponents were more in the severe mental illness. Religious wise, the Hindu population were more. And among among severe mental illness, 67% are unemployed, and majority are from rural area, and they are from majority are from middle socioeconomic status. And this is the distribution in the demographic value. And in the burden assessment scale, overall assessment, severe mental illness scored more than common mental disorder in factor 1, factor 1 and 3, 4, except in factor 5, which is not statistically significant. Even in the total score, which is statistically significant in factor 5, which is perceived severity of the disease, which did not come. Both severe mental and common mental disorder were equal, so it was not statistically significant. So we did not had equal sample distributions. We used statistically a Mann-Whitney U test. So this is a box and whisker plot where severe mental illness scored more than common mental disorder. These are the numbers are the outliers. In quality of life BREF, in that severe mental illness scored more in domain 1 and domain 3 and domain 4. Even in total score also, the severe mental illness scored more than in common mental disorder, except in domain 2, which is not statistically significant. The both values were equal. Here, the outliers are more seen in common mental disorders. In PHQ-9 scale, we observed that 39.9% on mild depression were noted in severe mental illness, and 61.8% on noted mild depression in common mental disorder. Overall, it was statistically significant. And Box-Whisker plots for common mental and severe mental disorder in PHQ, there were no outliers. And gender-wise distribution, the burden assessment scale score showed that female caregiver reported more burden related to their spouse or the male caregiver, but except in QAL BREF, burden assessment and PHQ-9, they were not statistically significant. In correlation with the questionnaires with scale, all three were statistically significant. Only in QAL BREF was nearly almost significant. In internal correlation with among scales, burden assessment SCAR with QAL showed a negative pattern. It was not statistically significant. BREF and PHQ-9, which was statistically significant, and PHQ-9 and burden assessment score statistically significant. These are the correlation with ages. These are scatter plots. Correlation with QAL and BREF. This is PHQ-9 with age, and this is correlation with burden assessment score and total scores. And discussion part, burden assessment scores showed that female caregiver reported more burden than the male caregiver because most of them were spouses, patients suffering from illness. The burden on them may be greater. They reported that the caregiver giving responsibilities were moderate to severe. In this study, among the caregivers, severe mental illness, majority of them were 41 to 50 years of, they were parents. Among common mental disorders, 31 to 40 years, they were spouse. In correlation with ages, what we particularly found in the study is increase in age showed increased in burden assessment score. Increased ages with QAL BREF also showed is almost significant in our study. And age increased, the score in PHQ also increased. Internal correlation between scores also, as the score in PHQ-9 increased, the burden assessment score also increased, showed an increased in pattern. PHQ-9 has decreased and quality of life also increased. And a similar study like Mira et al. Showed that majority of caregivers were middle-aged, educated, married, and employed, and they were either parents or spouse. And a caregiver profile from study from similar were reported same like in our study. And in this study, we found that disruption of routine family activities in the domain are significantly a higher mean score than any other domains. And other studies like Nera et al., like both bipolar affective disorder and schizophrenia suffers, families were disrupted. Limitation in study, this etiology and causative factor of this burden could not be assessed because it's a cross-sectional study. Sample size were limited, and then the sample size were in unequal distribution. Conclusion, most of the mentally ill patients are being cared at home by the family members and friends. Therefore, it's very important to monitor the mental health of the caregiver to maintain the well-being of the mentally ill patient. It's important of the healthcare professional to be aware and of the sensitive needs of the informal caregiver, and the quality of life burden instrument is thus the best way to measure the impact of the intervention. This is my reference. Thank you.
Doctor, I have a query. Was this OP or IP patients? OP patients only. Was that factor considered? Because I worked in Kapagavana. You have, all departments are there. There are some caregivers who have, two family members, one in a psychiatry department and the other. Was that considered?
the primary caregiver who are coming with the patients regularly. We are taking follow-up patients only now.
No, my question is, some caregivers have two patients in two different specialities. It does happen there. One in the medicine department or one in the OG, the other in, of course, psychiatry. Was that factor considered?
No, ma'am. Only we are taking the primary caregiver. Mostly spousals or who are coming regularly with the patients.
Sir, I think you didn't get your question. Ma'am is asking that you are taking history from caregiver, right?
Caregivers.
அவங்க சொல்றது என்ன அப்படின்னா கிம்ஸ்ல வந்துட்டு the caregivers in two different sectors. Did you only but what his answer is you only took the history from the primary caregiver of the psychiatric patient,
Okay,
not
that
from
was.
the medical.
Yes, it does happen there because I work there. I think there are two specialties, two patients will be there, only single caregiver. They'll be running between this department and that department. That adds a lot of burden for that.
No, ma'am.
Caregiver.
Only psychiatric. Only the
that
psychiatric
was-
one, not the medical. Severe mental. Yes. Yes, sir. Caregivers. Yes, sir. Yes, sir.
Did you include caregivers of dementia patient?
No, sir.
Dementia is not included.
Thank you, sir.
Please check on to time.
Thank you, doctor. The next presenter is Dr. Chitra.
Good morning, everyone. My study topic is prevalence and risk factors of anxiety and depression during pregnancy. And introduction, the pregnancy and the postpartum period. Ma'am, this is the old one. Yes, ma'am. Yes, ma'am. Introduction. Pregnancy is a period where a lot of physiological, hormonal, and hemodynamic changes in your body, which is a very stressful stage. Most women experience physiological disturbances like irritability, agitation, and mood swings due to above changes. There are evidences that just being pregnant can induce loading amount of anxiety and depression in a pregnant woman. And there are varieties of social and obstetric factors which causes anxiety and depression during pregnancy, like age, education, type of family, previous abortion, family support, male child pressure, etc. A lot of studies have been done across the world and even in India to find the prevalence of anxiety and depression among pregnant women. In this study, we are intending to see the prevalence and also the risk factors which attributes to the anxiety and depression during pregnancy. And these are the objectives to estimate the prevalence of anxiety and depression during pregnancy, to determine the risk factors of anxiety and depression during pregnancy. Then the methodology, it is a hospital-based cross-sectional study and done in a OPD department of obstetrics and gynecology in Karpaga Vinayaga Institute of Medical Sciences and Research Center. And the study was conducted for the duration of 3 months from March to May 2022. And the study population is the antenatal women attending antenatal OPD in the OBG department. The inclusion criteria were all antenatal women, irrespective of gestational age, having no other comorbidities, willing to give the consent and to participate in the study were included in this study. The exclusion criteria were pregnant women with complications of hypothyroidism, hypertension, diabetes mellitus, epilepsy, and mental illness like depression, anxiety, and schizophrenia, and other mental illnesses were excluded in the study. Pregnant women who have come for medical termination of pregnancy also excluded, and patients who are not willing to participate is also excluded in this study. And the sampling method was purposive sampling method, and the sample size was calculated by using the formula n equal to 4pq by d square. Based on the study, Dahiya and et al., by using the 21% of depression prevalence, 8% absolute precision, 80% of power, the sample size was calculated as 125. The study instruments used are a semi-structured questionnaire for the sociodemographic
the factors including the socio-demographic profile and the obstetric and the social factors, Edinburgh postnatal depression scale, perinatal anxiety screening scale. A semi-structured questionnaire contains socio-demographic characters include age group, education, occupation, employment status, residence, religion, and type of family. Obstetrics and gender-related characters include gestational age, history of abortion or stillborn, alcohol intake by the spouse, preference of male child, perceived social support from partner or mother or in-laws, and the physical violence. And Edinburgh postnatal depression scale, it's a 10-item questionnaire, is a valuable and efficient way of identifying patients at risk for perinatal depression. Mothers who score above the 13 are likely to be suffering from a depressive illness of varying severity. And the perinatal anxiety screening scale, it is a 31-item scale. Each item has scoring ranges from 0 to 3 and designed to screen for anxiety in both antenatal and the postpartum women. And the subscale includes excessive worry and the specific fears, perfectionism, control and trauma, social anxiety, acute anxiety and adjustment. And the severity scoring, that is the score ranges from 0 to 20 is considered as asymptomatic, 21 to 41 considers mild to moderate symptoms, and 42 to 93 considers severe symptoms. And data collection, the primary data collected by the questionnaire method. And first, to conduct this study, the ethical committee approval was obtained from our college, IEC committee. And then the the permission from the OBG department in KIMS was also obtained. And after that, the patient were willing to give the consent were included in this study. In this study, totally 125 mothers were assessed for prevalence and risk factors of anxiety and depression during pregnancy using EPDS and PAS scale. And data analysis were entered in MS Excel 2015 and analyzed using SPSS and SPSS software 23 version. Qualitative variables were analyzed by using proportions, and quantitative variables were analyzed using mean and standard deviation. So, test of significance was assessed by chi-square test, and risk was calculated by odds ratio. And the results, this study was conducted among 125 antenatal women who attended OBG OPD. The mean age of antenatal women was 25.78 plus or minus 4.45 years, ranging from 18 to 38 years. The mean age of spouse was 31.18 plus or minus 4.961 years, ranging from 22 to 42 years. The majority were educated up to higher secondary education and unemployed currently. 95.25% of them were Hindus, and there was an equal distribution among the type of family. A higher proportion of attendees were from rural area, and 48% of them had less than 5 kilometers distance from their home to hospital. And this is the mean score, the scales used. And the factors associated with depression are age less than 30 years, higher education, more distance from hospital to their home, and history of abortion, absence of in-law support, and alcohol consumption by the life partner, male child preference, and the physical violence or verbal abuse were associated with the depression. Factors associated with anxiety are nuclear family dwellers, more distant from the hospital to their home, absence of in-law support, male child preference, and physical or these are the results. Among 125 patients, totally 17 patients has anxiety, and 21 patients, antenatal mothers, were having depression. And this table shows the association between the depression and the socio-demographic characters, that is the age group less than 30 years, and education, that is particularly the graduates, and proximity to the hospital, particularly the distance, has association with the depression, because the p-values are also significant in this study. And association between the depression and the obstetric and social factors, that is history of abortion, gestational age, particularly the first trimester, perceived social support from in-laws, alcohol consumption by the partner, male child pressure, physical or verbal violence were associated with the depression and has the significant p-values. And this is the association between anxiety and the social demographic characters, type of family, proximity to the hospital. And this is association between anxiety and obstetric and social factors like physical, verbal violence, perceived social support from in-laws, male child pressure as significance in this study. This is a discussion. The study by Dahia and et al. In North India shows the result of 21% of antenatal depression. and-
Time finish.
Okay, sir. And the study results were also same in our study. And okay, sir. And come on to the conclusion. And 13.6% of unrelated women had anxiety disorder, and 16.88% of them were depressive in our study. India is a large country with significant cultural and regional diversity, resulting in disparities in risk factors and outcomes. Recognizing mother mental distress by healthcare providers during pregnancy has been identified as important action for reducing mental depression burden and improving child's outcome. These are my limitation. That is because it includes only 125 participants, and these are my references. Thank you.
The paper is open for discussion. Any question?
Yes, sir. Because because they can worry about the distance from their house, sir. Because whenever the, no, nearer the hospital, the depression is lower. Farther the hospital distance, the depression and the anxiety prevalence is high. Yes, sir. Yes.
I have a doubt. So which you included all the 3 trimesters, or it was only 50%?
Sir, we have included all 3 trimesters.
Being a private hospital again, with all that freebies given by the government, we don't get so easily, right? And in case you cannot get 125 so easily in a span of 3 months.
Yes.
This is one area which I want you to clarify. Because I work for a private institute, and with all the freebies around, every PhD has to register, right? So did you really get the 125, or it was some multiplies of certain number?
Sir, no, sir. Really, we got 125 patients. Because in 3 months we got.
No, you understand, but being in a private institute, I just wanted to clarify.
Yes, sir, we got the
You
patients.
go for the treatment for the diagnosed patient.
No, sir. We just only identify the prevalence, sir. Thank you, sir.
Thank you, Dr. Chitra. The next presenter is Dr. Aish.
Good morning, everyone. Today, I am going to present about a case which was of delusional parasitosis in old age women. Starting from the introduction, delusional parasitosis, as we all know, is an uncommon psychotic illness, and it is also called as Igbom syndrome. Delusional parasitosis is mostly characterized by an unshakable false belief of having been infested by a parasite when there is no evidence of infestation. Usually, it is described in middle-aged and older women, but the condition is also be seen in all patients from all the age groups. Due to the paucity of publication, the prevalence of delusional parasitosis is unknown. Patients often report to dermatologists first and other physicians for the treatment, and then they are brought to psychiatric attention only for associated psychological distress. Many patients may resist the idea that their condition may be psychiatric and may refuse the referral for psychiatric care also. More studies in this field leading to more evidence may help in future for better understanding of clinical presentation and management as it involves multidisciplinary field. In this case, I would like to introduce Mrs. K, who is age 65-year-old, female, married. She's a housewife and was referred to for psychiatric evaluation from dermatology department in a view of history suggestive of trichotillomania, according to the dermatologist. And complaints were of patchy hair loss over exposed area since two months, and which was secondary to behavior of repetitive hair pulling. And patient reported to have the sensation of insects or bugs crawling on her skin. Following the sensation, patient tried to catch bugs on her skin. In that order, she pulled her hairs to find them, and leading to excoriation and abrasion lesions. Patient firmly believed that these are little bugs and not convinced with other explanation given by the physicians and family members. In this picture, we can see that how many lesions she had made by plucking the hair, and these are the presentations that these are the things that patient will present with multiple lesions on their skin and hair loss. In this case history, past medical history includes the diagnosis of hypertension from 7 years and cataract surgery 8 years back. Family history was unremarkable and no sign and symptoms signifying neurological and cerebral dysfunction on examination was seen. Patient was started with second generation antipsychotic, that is oral form of risperidone 2 milligram per day. Patient showed 25% improvement only as frequency has decreased, and dosage of risperidone was increased to 4 milligram in the next follow-up to achieve better remission. After 2 months, when patient stayed 2 months off medication as she was improving, she had relapse of symptoms with some of the depressive cognition. Coming to the discussion, patient and her family members, they initially considered as dermatological problem and got referred to psychiatrists with suspicion of similar presenting disorder as trichotillomania. Careful evaluation of patient psychopathology was the important factor to make diagnosis of delusional disorder. Trichotillomania secondary to delusional parasitosis is a very rare presentation, and 1 or 2 case reports have been presented, and it can be considered a differential diagnosis. Patient responded well to second generation antipsychotics, therefore strengthening the evidence for neural mechanism involved is same in other psychotic disorder. Coming to the conclusion, delusional parasitosis often would present to non-psychiatric medical professionals first and then to psychiatrists second. Patient must be adequately evaluated about their symptoms and beliefs about the causative factor and likely etiology. Management can be challenging as many patients may refuse psychiatric explanation of the symptoms and may refuse referral for psychiatric care. Better awareness of such illness by general physicians, early recognition, good repo, and timely referral and empathic treatment are the cornerstone of management in such cases. Thank you. These are my references.
It's a good try, but we would say like it was given for a trial for you to get exposed to the crowd. Otherwise, the case does not have anything new because it's already very common and it's been seen in day-to-day practice. At least it's not so rare, but it's a good try.
Thank you.
Take it in the wrong sense. Maybe in the next conferences, we wish you take something new and innovative.
Yes, sir. Thank you, sir.
Is she diabetic?
No, sir. Thank you, sir.
Thank you, Dr. Aish. Next presentation is by Dr. Zulfat Moeedi.
Good morning. My topic is on case report of a young woman with intellectual disability, epilepsy, and psychosis of unclear prognosis. Coming to introduction, there are few studies conducted that included people with intellectual disability and episodes of seizures and psychopathology eliciting psychosis, even when the prevalence of epilepsy in general population and those with intellectual disability remains high. Psychotic symptoms may appear in different ways when epilepsy is present, making difficult to diagnose and further classify into specific types. Here the challenging task is to diagnose psychosis in people with intellectual disability in presence of recent episodes of seizures and to state treatment outcomes. Cases with the documented psychosis with its type extension in individual's lifestyle helps in understanding the pattern of illness and pharmacological treatment outcomes to be expected during the management of psychosis, especially when expecting the complete remission of symptoms. Altogether, this makes it necessary to report cases which comprises work eliciting psychosis and seizures in people with intellectual disability, highlighting the reason for future studies and requirement of well-structured guidelines. Miss R, 20-year-old unmarried female presented with a history of talking to self and suspiciousness for the past 2 years. Patient was observed to have conversation when alone related to her family safety. Patient expressed her fear that someone is about to harm her and her family. Patient often checked windows and doors whenever suspected someone is spying on her. Patient also refuses to consume food prepared and served by anyone except her mother, as the patient trusted her. Symptoms signifying neurological and cerebellar dysfunction
functions such as giddiness, gait disturbance were absent. There was no history of substance abuse was found. The patient had the first episode of seizure at the age of 3 years, and then second episode was 2 years back. Past 2 years, the patient had nearly 20 episodes of seizures with the same pattern of generalized tonic-clonic seizures each time, and the patient was on maintenance therapy with valproate 200 milligram orally thrice for 2 years. Patient's psychotic symptoms started 2 weeks after the second episode of seizures, which was 2 years back. She had support from family members for day-to-day activities and self-care. Patient was able to complete her schooling till 6th standard, after which the patient was unable to pass her exams. After the assessment, she was found to have a mild intellectual disability. CT scan revealed no significant findings, and blood investigations was within normal limits. Family history was unremarkable, and patient was started with antipsychotics risperidone 1 milligram morning and 2 milligram at night, THP 2 milligram and diazepam 10 milligram. As according to patient's caretaker, patient was unable to fully achieve premorbid living. After multiple such consultations from different physicians who kept on modifying the treatment, the patient is now on oral medications including antipsychotics, risperidone 3 milligram, mirtazapine 15 milligram, and nitazepam 10 milligram. Anti-epileptics initially were changed from phenytoin to sodium valproate, and 4 months ago it was again changed to phenytoin 100 milligram in morning and 200 milligram at night, which resulted in better control of epilepsy. With changes in medicines, any change in psychotic features remain significantly inappreciable. Coming to discussion, neuropsychiatric manifestations in people with intellectual disability are mostly underreported and misdiagnosed, and sometimes they remain untreated. So this case highlights a pattern of psychosis and its extension in the patient's life, adding up the functional impairment that's already present due to intellectual disability, which finally lead to multiple consultations from different specialists and then changes in the choice of treatment. People with intellectual disability, there is a higher chance of developing drug-resistant epilepsy, leading to higher chance of sudden unexpected death. As in previous research, phenytoin is considered as a possible risk factor for the development of psychosis in low intelligence level. So it's important to carefully prioritize the desired outcome and drugs to achieve the same. In this case, use of phenytoin before and restarting again was more dependent on clinical judgment of appropriate treatment for epilepsy, and by the use of sodium valproate, a balance of preventing seizures and psychosis was tried to achieve. So appropriateness of the diagnosis and management of episodes of seizures become essential to reduce the considerable social impact, potential stigmatization, secondary handicap, and low self-esteem compounded by social exclusion as seen in people with intellectual disability. So in future, with increased number of studies, including individuals having together with intellectual disability, epilepsy, and psychosis, may help in forming a well-structured guidelines and predictability of treatment outcomes to guide the clinicians in this field. These are my reference. Thank you.
Thank you, Dr. Zulfat. Our next presenter is Dr. Delna Sani.
Good morning, everybody. My topic is relationship between self-compassion and stress among undergraduate medical students. Introduction. The study of medicine perceived as stressful and negatively impact physical and mental well-being of students. Prevalence of stress among medical students estimated as 28.5% to 78%. Self-compassion is the ability or tendency to respond to the self in times of failure or distress with gentleness, kindness, and understanding. Recent studies shown that it acts as an emotion regulation strategy to promote psychological health. It received limited attention in Indian studies, and this study aimed to determine the relationship between self-compassion and stressors among MBBS students. Objective: to determine the relationship between self-compassion and stressors among MBBS students. Data and methods. Subjects is MBBS students in VMKV Medical College and Hospital. Study design is cross-sectional study. Sample size is 278. Inclusion criteria is students who are more 18 years of age, students from 1st, 2nd, 3rd, 4th MBBS. Exclusion criteria, students less than 18 years of age, students already on any psychotropic medications. Data and methods. A cross-sectional study conducted among 278 MBP students who responded from 450 students of MKV Medical College and Hospital. After written informed consent, student was given a socio-demographic profile sheet. The source of stress was assessed using the medical student stressor questionnaire. The self-compassion was assessed with self-compassion scale. Tools, socio-demographic profile sheet, the medical student stressor questionnaire, which consists of 40 items representing the six domains of stressors. The 6 domains are academic-related stresses, intrapersonal and interpersonal related stresses, teaching and learning-related stresses, social-related stresses, drive and desire-related stresses, group activities-related stresses. Self-compassion scale is a 26 items, consist of 6 subscales: self-kindness, self-judgment, common humanity, isolation, mindfulness, and over-identification. Statistic and analysis. Correlation were examined by Pearson correlation coefficient. Result: total self-compassion mean score is 3.10, which comes in moderate self-compassion. Self-compassion mean score of males 3.16 is more than females 3.07. Other socio-demographic correlates were not significant in this study. Non-parametric correlation analysis week showed weak, statistically significant negative relationship between domains of stressors and self-compassion for the entire data, which is shown in table 1 and plot 1. This is the correlation between 6 domains of stressors and self-compassion. In each 6 stresses, the correlation with self-compassion is negative, and p-value is also significant. The correlation is shown in the scatter plot in each domains of stressors like academic, drive, group activities, intrapersonal, social and group activities related stresses. The self-compassion is negatively correlated. Discussion. The study showed negative correlation between self-compassion and stress. The result is similar to other studies. Results suggest that high self-compassionate individuals experience less stress, which is consistent with the reviews of the self-compassion literature. Conclusion. The present study confirmed association between self-compassion and stress that is consistent with previous studies. Self-compassion intervention can facilitate effective stress management and can improve psychological health among medical students. It's my references, and thank you. The stress level is moderate stress level among the medical graduates. Actually, I'm conducting stress management interventions on medical students. It is my part of thesis, but self-compassion I added for my.
Thank you, Dr. Delno. Next presenter is Dr. Jayashree. She has 2 papers to present.
Good morning to one and all assembled here. I am Dr. Jayashree, final year psychiatry PG from KAPV Government Medical College, Trichy. My study is on a study on prevalence of depression and its association with self-esteem among patients with generalized tonic-clonic seizure attending neurology OPD. I thank my faculties for supporting me in this study. Introduction. A seizure is a transient paroxysmal pathophysiological disturbance of cerebral function caused by spontaneous excessive discharge of neurons. Patients are said to have epilepsy if they have chronic condition characterized by recurrent seizures. 2 major categories of seizures are partial, that is epileptiform activity involve localized brain regions, and generalized, which involves the entire brain area. Generalized tonic-clonic seizure exhibit classical symptoms of loss of consciousness, generalized tonic-clonic movements of the limbs, tongue biting, and incontinence. The post-ictal state is characterized by slow, gradual recovery of consciousness and recognition. The manifestation of depression in epilepsy is a complex issue having many interacting neurobiological, psychosocial determinants, including clinical features, seizure frequency, type, foci, or lateralization of the seizure, and neurochemical and iatrogenic mechanism. Other factors include family history of psychiatric illness, control over seizure treatment with anti-epileptic drugs, social coping and adaptation skills. The uncertainty and unpredictability may instigate sadness, loneliness, despair, low self-esteem, and self-reproach in patients with epilepsy and lead to social isolation and stigmatization. Despite its high prevalence of depression among generalized tonic-clonic seizure patients, it continues to be under-recognized and undertreated. Hence, the study aims to estimate the prevalence of depression and its association with self-esteem among generalized tonic-clonic seizure patients attending neurology OPD at MGMGH Trichy. Methodology. My study is a cross-sectional study. It includes 60 generalized tonic-clonic seizure patients. Age ranges from 17 years to 67 years. Study duration is 2 months from 1/12/2021 to 31/1/2022. Study center is neurology OPD at KPV Government Medical College Trichy. Methodology. Approval from Institutional Ethical Committee and for all individuals, informed and written consent was obtained. Known generalized tonic-clonic seizure patients identified by ST and phenomenology. Using semi-structured proforma, socio-demographic details were obtained, and the scales used were Beck's Depression Inventory and Rosenberg Self-Esteem Scale. Beck's Depression Inventory is created by Dr. Aaron T. Beck, published in 1961. It can be self-scored. It has 21 questions. The score ranges from 0 to 3. Maximum score can be 63 and the minimum score can be 0. The 1 to 10 is this ups and downs are considered normal. 11 to 16 mild mood disturbance. 17 to 20 borderline clinical depression. 21 to 30 moderate depression. 31 to 40 severe depression. Over 40 extreme depression. Rosenberg Self-Esteem Scale. It was developed by the sociologist Maurice Rosenberg. It has 10 questions. 5 of the items are positively worded statements and 5 are negatively worded ones. The scale measures global self-worth by measuring both positive and negative feelings about the self. It is a reliable and validated tool for self-esteem assessment. Each question has scores between 0 to 3. Scores below 15 is considered low self-esteem. Inclusion criteria. All male and female patients with generalized tonic-clonic seizure in the age group of 17 to 67 years who attended neurology OPD for review and follow-up were included in the study. Patients with other forms of generalized generalized seizures and partial seizures were excluded from the study, and patients who have not given their consent were excluded from the study. Results of the study. The frequency table. Most of them were in the age group of 41 to 50, that is 35%. Most of them were male, 66.7%. Most of them completed their schooling, 75%. Most of them were working, 81.7%. Most of them were married, 70%. Most of them had their child, 70%. Most of them from upper lower socioeconomic status, 48.3%. Most of them had seizure duration more than 10 years, 55%. Most of them had number of hits more than 10, 63.3%. Most of them had no other stressors, 78.3%. Most of them had low self-esteem, 56.7%. And most of them had mild mood disturbance, 26.7%. The results based on the chi-square test. There is a statistical significant difference exists between gender and self-esteem, and also between gender, working status, and depression. It's shown in this table. The depression is chi-squared among the socio-demographic profile, in that statistical significance exists between the gender, working status, and the depression. In this chi-square table, statistical significant difference exists between gender and self-esteem. The correlation analysis using paired sample t-test and intercorrelation matrix was done. This study shows strong positive correlation between low self-esteem and level of depression among GTCS patients. That is, self-esteem has negative correlation with the level of depression. This is the table showing that significant statistical significant difference. The intercorrelation matrix also explains the same. The self-esteem, as the level of self-esteem decreases, the level of depression increases, and vice versa. Discussion. In the study, generalized tonic-clonic seizure patients shown significant level of depression and low self-esteem due to the nature of disease process like unpredictability, long-term treatment, and its secondary impact on multiple psychosocial factors. Other stressors adds on to the severity of depression and low self-esteem. Self-esteem has negative correlation with the depression. That is, the level of depression increases with as the self-esteem goes down. Limitations of the study. Can't generalize the finding as it is carried out in institution level, not at population level. The sample size should be sufficiently large enough to estimate the prevalence with adequate precision. These were my references. Thank you.
The case is open for discussion.
Thank you.
Did you exclude levetiracetam drug?
We have not taken into consideration the kind of drug they were taking, sir. We have generally taken all generalized tonic-clonic seizure patients attended the OPD, sir.
Drug-wise, you have not separated.
Yes, sir. Thank you, sir. Good morning. My next topic is the study on pattern of attachment style and its association with self-esteem among CRRI doctors at KAPV Government Medical College, Trichy. Introduction: a person's psychological health and sense of well-being depends significantly on the quality of his or her relationship and attachment to others, and a core issue in all close personal relationship is establishing and regulating that connection. In a typical attachment interaction, one person seeks more proximity and affection, and the other either reciprocates, rejects, or disqualifies the request. The pattern is shaped through repeated exchanges. According to attachment style, paraphrased from Azen and Shaver 1987, the anxious or ambivalent type of attachment style view love in an obsessive way with strong need for reciprocation, validation, along with emotional highs and lows and feelings of jealousy. Avoidant attachment style are relatively uninvested in close relationships, although they often feel lonely. They seem afraid of intimacy and tend to withdraw when there is stress or conflict in relationships. Secure type of attachment style describe their relationship as friendly, trusting, and happy. They accept their partners regardless of the faults. They tend to have long, fulfilling relationships. So, dysfunctional attitudes about an individual's sense of self is thought to affect self-esteem, a more proximal and accessible predictor of psychological distress. As compulsory rotatory residential internship doctor is a stage where they started their studies in late adolescence and leaving as adults might have undergone much shaping in their attachment style. Hence, to throw lights on this study was conducted. Aims and objective to estimate the prevalence of pattern of attachment style and its association with self-esteem among 2017 batch CRRI doctors at KAPV Government Medical College, Trichy. Method: it's a cross-sectional study, includes 80 CRRI doctors. Age ranges from 21 to 26 years. The study duration 10 days from 1/6/2022 to 10/6/2022. Study center is at KPV Government Medical College, Trichy. Methodology: approval from Institutional Ethical Committee, and for all individuals, informed and written consent was obtained using semi-structured proforma, socio-demographic profile obtained. Scales used are original attachment 3-category measure. Those who selected insecure attachment styles like anxious and avoidant were given experiences in close relationships revised questionnaire. Then the Rosenberg self-esteem scale was applied for all. Original attachment 3-category measure. It is the first measure of adult attachment. It has 3-item questionnaire which gives the answer as secure type, avoidant type, or anxious or ambivalent type. Those who fall into either of the two insecure attachment styles were given experiences in close relationship questionnaire to confirm what kind of insecure attachment type they were in. Experiences in close relationships revised questionnaire. It's a 36-item measure of adult attachment type. The questions are divided on 2 subscales of attachment: anxiety, who tend to fear rejection and abandonment, and avoidant, who find discomfort with intimacy and seek independence. First 18 items comprise attachment related anxiety scale. 90 to 36 comprise attachment related avoidance scale. Each question is scoring 1 to 7. Each subscale, the minimum score is 18 and the score maximum score is 126. Rosenberg self-esteem scale. It was developed by sociologist Maurice Rosenberg. It has 10 questions. 5 items for positively worded statement and 5 items for negatively worded statement. Scores below 15 considered low self-esteem. All male and female CRRI doctors of 2017 batch KAPV Government Medical College, Trichy, who gave consent were included in the study. Who have not given the consent were excluded from the study. The statistical analysis using SPSS 22 software. Results include most of them belong to the age group of 22, 42.5. Most of them were female, 60%. Most of them studied at English medium, 91.3%. Most of them from private schools, 88.7%. Most of them had siblings, 81.3%. Most of them from Tamil Nadu, 88.8%. Most of them from upper class, 43.8%. Most of them had no associated comorbidities, 83.8%. And most of them had no significant family history, 81.3%. Most of them were extroverts, 76.3%. Most of them had normal self-esteem, 52.5%. Most of them showed insecure type of attachment style, that 55%. Descriptives: mean self-esteem score was 20.5 and mean anxious subscale score was 27.11. Mean avoidant subscale score was 32.40. Results based on chi-square test. There is a statistical significant difference exists between self-esteem and attachment style, that is anxious type of attachment and low self-esteem as statistical significance. Also, reciprocal relationship established between anxious and avoidant attachment style, that is low anxious persons are highly avoidant and vice versa. This is the table showing the statistical significance. The anxious persons have low self-esteem more. This is the chi-square test showing the avoidant persons are low anxious and the highly avoidant persons are highly anxious persons are low avoidant. So correlation analysis using intercorrelation matrix. This study shows strong positive correlation between low self-esteem and anxious type of attachment style. This is the table showing statistical significance. Low self-esteem persons having statistically significant anxious type of attachment style. Discussion in the study, as most of the doctors have secure attachment style, which is a good thing. To the other two extremes of insecure attachment style, which have its own relationship problems, we can try to psychoeducate them to certain extent, which may help to reshape their attachment style to certain extent in a secure way. Thank you. Thank you.
Thank you, Dr. Jayashree. And we have the last presenter for today's session.
Good morning, everyone. I'm Dr. Ashwini, a third year psychiatry resident from Sri Ramachandra Medical College. And my topic was on depression in patients with type 2 DM and its association with glycemic control. For a brief introduction, we know that the recent several studies showing all over the world that the prevalence of type 2 DM has been increasing, and it poses a serious threat to the public health. Especially in India, the prevalence of depression has been increased. The prevalence of diabetes mellitus type 2 has been increased in urban areas from 3.3 to 19% and 2.4 to 15% in rural areas in the last 2 to 3 decades. Depression comorbid with type 2 DM is a major contributor for the DALYs lost in these individuals. And a lot of studies shows that there is a bidirectional relationship between depression and diabetes. Even in non-diabetic patients, a study shows that insulin resistance in these patients found to be associated with depressive symptoms. And patients having comorbid diabetes and depression found to have enhanced platelet hyperactivation, and it creates a pro-inflammatory states, which increases the susceptibility to cardiovascular and metabolic diseases. And we have also found significant association with cognitive impairment and sexual dysfunction, etc. in these patients. However, there is a dearth of evidence on relationship between depressive and glycemic control. So the objective of my study was to estimate the occurrence of depression in patients with type 2 diabetes mellitus and to find the association between the severity of depression and the glycemic control. This was a cross-sectional study done in a period of 3 months from April 2022 to June 2022. And the sample size taken was 106 patients. And this was conducted in the Department of Endocrinology in the patients who come to the outpatient setting in Sri Ramachandra Institute of Higher Education and Research. And ethical clearance was received from the Institutional Ethics Committee. Patients from the age of 18 to 65 years were included who has a confirmed diagnosis of type 2 DM for at least 6 months and who are independent in terms of their activities of daily living. And patients who are not willing to provide consent or with a history of severe or debilitating physical illness or severe mental illness was excluded. Patients with the diagnosis of type 2 DM, at least for 6 months, who fit into this selection criteria was scrutinized in the endocrinology OPD, and the socioeconomic details were collected with informed consent. And the glycated hemoglobin levels were recorded from the patient with a maximum of 3 months duration. And the patient health questionnaire 9 was administered to all the subjects. Mini international neuropsychiatric interview was used to diagnose depression in the subjects, and HAM-D, Hamilton Depression Rating Scale, was used to assess the severity of depression. And the statistical analysis was done to estimate the prevalence of depression in these patients. And the t-test, independent t-test was done to find the association between depression in diabetic patients, the severity, and the increased glycated hemoglobin levels. These are the results. The patients of our study were from 29 to 65 years of age. Their majority, like 69.8%, were females, and 72.6% coming from an urban background. And a lot of patient, most majority of patient, up to 85% had some level of education. Almost 50, half of the patients were from joint families and half were from the nuclear families, and 72.6% were married. Almost 60.3% were unemployed. And patients, 49.9% were belonging to a lower class. And based on the medications, the patients were only on oral glycemics were 63.2%. And with the results, the patient having depression more, that is with a PHQ score more than 10 or more than 10, who was screened to have depression, or 24.53% in the total 106 patients. And the severity, patients of the 26 patients, 69.2% were found to have mild depression, and 30.7 had moderate depression. And the comorbid conditions, almost 55.6% had a history of systemic hypertension. And but the significant finding is that the patient who was found to have comorbid depression, that is 26 patients out of 106, 80.76% had a history of systemic hypertension. From the statistical analysis, here we can see that the mean HbA1c levels were comparatively high in patients who had depression. However, it was not statistically significant. And in the second table, we can see that well-controlled type 2 DM patients have a mean of only 5.51 PHQ-9 scores, whereas the poorly controlled have higher incidence of prevalence of depression symptoms. So discussion, we found that older age, female sex, and low socioeconomic status, and unemployment, and urban living found to be significant predictors of depression in the study. And the insulin usage was not significantly associated with depressive symptoms. We have found that the comorbid hypertension was found in 80.76 patients who had diabetes with comorbid depression. Hence, we have to look that systemic hypertension was an increasing contributor to the depression prevalence. Patients, as I told earlier, patients with depression are found to have higher mean HbA1c levels, but it is not statistically significant. While patients with poor glycemic control have a significantly high association with the presence of depressive symptoms. Conclusion, we know that there is an alarming rise in the prevalence of depression among the patients in type 2 DM in the last few decades. Despite not being able to establish a causal relationship between the type 2 diabetes mellitus and depression, but there is a significant association between the poor glycemic control and depressive symptoms. And we have to take, as a health professional, we have to take active measures to identify the risk factors and symptoms of depression in diabetic patients to improve the treatment outcomes in these patients. Thank you.
Any questions? Mike, I have a question. It's a good study, but why was that many used, and what was the interpretation from it? Okay. We're using many. You mentioned somewhere you used many.
Yes, sir.
What was the input from that?
Just to see the patient's depressive symptoms. Is there qualifying? After that, we have after mini, we have used HAM-D for
What
severity.
all else you can find out from the mini scale?
Sorry, sir.
What all you can find out from mini? What is mini scale?
Mini International Neuropsychiatric Interview.
So what will happen? What are the components?
There are 6 components. Low mood, depression, fatigue, loss of interest, any.
Good.
Thank you,
Is
sir.
there any fresh diabetic or long-term diabetic?
The duration of illness, it was ranging from 6 months to 20 years, sir, in the total study population, study group. Thank you, sir.
Thank you, doctor. Thank you, chairpersons. It's time to honor our chairpersons. I request Dr. Ganesan sir to honor Dr. Vinod. Dr. Ganesan is honoring Dr. Vinod. Thank you, Dr. Vinod. நான் கொண்டு வந்து கொடுக்குறேன். நான் கொண்டு வந்து கொடுக்குறேன். Dr. Ravi Kumar will honor Dr. Iqbal Sharif. Thank you. So we thank all the audience who were present here, and we also thank the AV team for their wonderful coordination and timely help. Thank you.